as you've heard about in previous presentations, does conflict with the principles that are set out by the WHO. So economic evaluation seeks to maximise health for a given budget. And so when it chooses between competing interventions, the focus is very much on average population health. And also when moving beyond health, it may indeed choose to maximise other outcomes of interest, such as, say, well-being or educational attainment. And of course, this makes the implicit equity judgment that additional outcomes, including health, are valued the same regardless of who accrues those outcomes. And in many decision-making processes, including the National Institute for Health and Care Excellence, NICE, there's little information available that's presented on the distribution of costs and benefits across a population. It's not clear who would benefit if a decision was made to implement what's regarded as a cost-effective intervention. And there's no formal process by the likes of NICE to reflect equity in its decision making. Decision makers, however, may benefit from reflecting equity into their processes, and this can be because of a number of different factors. So it may be that uptake, adherence, efficacy of interventions may be better in socially advantaged groups. And it's often the case that although we target a lot of resources at the most deprived groups, often the opportunity costs of interventions and health are most borne by disadvantaged groups. And it can be that in some instances, interventions can actually increase health inequalities. So that we would regard that as intervention generated inequality. And it's also the case that a policy that would result in the most equal distribution may not provide the greatest increase in overall health. So we potentially have this kind of difference, this trade-off that needs to be reflected. And it's sometimes the case that interventions are more costly to deliver to socially disadvantaged. Okay. And because of this potential conflict around who gains, who bears the costs, we need to consider these trade-offs, whereby we may forego population health to reduce health inequalities, or potentially exacerbate health inequalities through interventions that improve overall health. And we need to be aware of that kind of potential conflict. So when I talk about measuring inequalities, what types of variables am I kind of referring to here? So these would include things that are related to kind of socio-demographics, they're related to economic status, demography, and also geography as well. And I've got some examples here which include things such as social deprivation or ethnicity. And these are measures that are kind of commonly used as indicators in terms of distribution of health and outcomes. And there are different measures available to health economists and healthcare planners that enable us to gauge equity or inequality in health. There are different measures of variation or spread, and these include things that are quite simple measures that are quite easily interpreted, such as life expectancy and life expectancy gap within a population. Regression-based measures, which just go beyond that in terms of looking at the slope. And more advanced kind of entropy type measures that have been developed that have moved on from things like the Gini coefficient. And there are also measures that focus on the impact of a given change in the distribution of health. So for example, relative inequity. And this is the ratio between two groups. So it may be between those that would be regarded as in areas of which they were socially deprived and less deprived groups. And then also absolute inequality measures. So that would just be the absolute gap between those two groups. And these different indicators are obviously correlated because they're in essence trying to measure the same thing and also using bits of information that are also the same as well. But the conclusions about the magnitude of inequality can differ, and also the direction could entirely differ as well. So what do these different measures of inequality mean for ageing research specifically? So the first thing to know that I mentioned at the beginning is that older people have tended to be quite neglected in research on inequalities, and particularly thinking about inequalities that are generated as a result of delivering an intervention that's considered to be cost effective in terms of the average population benefits. There's been lots of work on inequalities that has focused on early years. However, of course, these inequalities in younger years and adulthood can have implication for older age. And inequalities in income in particular can also persist for pensionable age individuals. So the measures that I've mentioned on the previous slide do have implications for prioritisation and spending of healthcare budgets. So an approach such as the kind of fair innings approach, which takes the view that there's some kind of span of life years that we consider as society to be reasonable, that people should attain that, will inevitably attach a higher weight to younger individuals. And then something like an absolute measure may well favour younger individuals, again, because individuals at an older age would be considered to have incurred their stock of health. And whereas relative measures may favour older individuals. So in the new NICE guidance for appraisal, which some of you may be aware of, both absolute and relative methods are going to be used, which potentially may produce a more kind of even spread compared to the previous criteria that's been used to think about allocation by NICE. And I've got an example of what that means here. So we can see on these two figures, which compare the number of appraisal topics by NICE that would have received the end of life modifier, which is the old weighting method, and then the severity weighting, which is the new method that's proposed by NICE. And we can see that many more topics received the end of life criteria, and thus were likely to be funded even if high intervention costs prevailed. So they were more likely to fund those topics for groups that are age 60 plus. And so the new weighting is more equitable. Okay, so we get a better spread, but it may mean that there's less approval of topics that are targeted towards older groups. So that potentially will have an implication going forward. Although there are a few issues to work out with NICE around how they implement this severity weighting, this is one potential consequence. So next I'm going to give a quick overview of a technique that's been mentioned, I think, in Matt's talk, which is used to bring together cost effectiveness analysis with measurements of inequality, and it does so using a single framework. And this technique is called distributional cost effectiveness analysis, or DCEA as we call it. And it provides a distributional breakdown of who gains most and who bears the largest burdens in terms of opportunity cost when we conduct a cost effectiveness analysis. And this can be used then to employ equity weighting to explore that trade-off between efficiency and equity. And in essence, it looks at the total costs and benefits, or perhaps it converts those benefits into a kind of monetary unit using something like incremental net benefit. And it looks at those as a distribution of benefits and costs, reflecting different relevant characteristics, such as socioeconomic deprivation, for which there's data to distinguish those groups of individuals that's pulled through an economic model. So these are the steps to conduct a distributional cost effectiveness analysis. So we first need to estimate that baseline health distribution, that distribution of health. And then we model changes in this distribution due to different competing interventions. And I won't go through the detail there, but we then use this estimated distribution to quantify the change, so the baseline compared to the change, in total population health, okay, and costs as well. And we look at unfair health inequalities due to each intervention. We can then go on to rank those interventions based on, as previously been described, kind of specific criteria. So which ones, you know, represent a cost-effective use of resources, and then go on from that to think about any trade-offs between improving population health and reducing unfair health inequalities. So this is what it looks like kind of in practice in terms of the steps. And as I said, I struggled to find an example that was related to ageing research to kind of illustrate this. So apologies that this is a rather more kind of generic example. So this is an example of what would be generated from distributional cost effectiveness analysis. So I've specifically kind of pulled out the QALY results here. So we can see here who gains additional QALYs according to subgroups that have been specified by sex and IMD. And then this information on distribution of benefits and then also opportunity costs, so we do this on the cost side as well, can be compared against the results from the cost effectiveness of the overall population, so not split down by these different subgroups. And this is what we might do if we're trying to make that comparison here. So we can think about those trade-offs between efficiency and equity. And for scenarios in the southeast and the northwest quadrant, we'd need to think about how much equity and efficiency you'd be willing to forego if a cost ineffective or an intervention that widened inequalities was implemented. So you'd need to think about these trade-offs. And I've put the link in here to the equity dashboard, which enables you to do that. And this is downloadable for free for anyone that's interested in thinking about these trade-offs and having a go. So the last thing I wanted to discuss are additional challenges for equity assessments when using a multi-sector approach. So in addition to the challenge of reflecting, you know, different outcomes across sectors, where additionally trade-offs have had to be made across sectors, we also need to think about equity impacts across sectors. And it may be relevant to consider equity in multiple different outcomes and also opportunity costs. And perhaps, you know, each of those have got different weights in order to think about trade-offs. So we may have a different weight in terms of efficiency and equity in one sector versus another sector, which kind of further complicates things. And even within a single sector, for some sectors, there's no single measure of benefit, such as the QALY, which makes the consideration of equity kind of further complex. And I've indeed been involved in conversations with public health people where they've talked about, for a local authority perspective, actually they don't often have a single outcome of interest for some of the programs they're interested in commissioning. And that makes it really, really complex to think about those trade-offs. And then in addition to that, there may be multiple social variables that are used to generate those groupings, and they themselves may be subject to kind of trade-offs. There may be benefits in some groups and opportunity costs incurred in other groups as well. So just to illustrate some of the kind of complexities in implementation of these techniques. So that's it from me. I've just put some links to some helpful resources there, the equity kind of dashboard, and also there's various bits of tools around as well to help people to kind of think about equity issues. Thanks.
Great, thanks ever so much, Laura. And I think that was another demonstration that we economists are not just there just to calculate costs along people's trials, but we've got some really deep thinking and some really nice kind of issues about trade-offs. Got a couple of questions for you. One of them I wonder whether Tristan Snowsill wants to make the comment himself. Just give him a second to see if he appears, but if not, I'll just kind of read out the comment he made. It was interesting. So Tristan, I don't know if you're able to come in, but if not, I'll just read out what it says. So he said, the equity consideration and opportunity cost is so interesting because if disinvestment takes the form of raising thresholds for, say, referral treatment or increasing waiting times, they might disproportionately affect the number of already disadvantaged groups. So Laura, I don't know if you wanted to say something.
I mean, I agree. I didn't talk about disinvestment as such, but I agree that, you know, that's another whole host of issues around, disinvestment. I was thinking more about investment, but disinvestment, you often find disproportionately it will affect those more disadvantaged groups. I think, I mean, it's a whole, you know, can of worms, isn't it, really? I think it's relevant for us to consider, you know, think about equity and think about trade-offs that we make, and ideally not implement interventions that increase health inequalities. But actually it's massively complex because we're not even just talking about one measure of inequality here, you know, and even within that we can be, you know, gaining and losing from different sectors of a population. So no, I don't have an answer, but I agree that it's also a challenge. I don't know if anyone's got the answer to that.
Well, we can add it on as the list of something for future research, can't we? We can add it to the list. I suppose we've probably just got time just for John. So John, I think probably John Silcock this is. I don't know whether we'll be able to get John in time because I think someone has to unmute for it to happen. But John has raised the question, I think it's a serious one, about whether there's any new people looking like community-based results. Oh, here comes John, I think. John, do you want to make the point yourself?
Thanks, Matt. Yeah, I was just wondering if there was anybody looking at community-based approaches to resource allocation, which was something that Gavin Mooney was most famous for, I think. And I just wondered if anyone had taken that up really and was developing those methods as well, because Gavin obviously was one of the prime movers, wasn't he, in incorporating equity in economic evaluation.
Yeah, so there is a reasonable amount of stuff going on here from someone called Richard Cookson, who's done a lot of this stuff, and actually the kind of the equity trade-off stuff and a lot of the material I put up there, that would be, you know, from Richard Cookson. I understand that he's kind of delving into that area. The specifics of what he's doing, I'm not entirely sure, but he has a as well as the equity dashboard, he's got a web page, and I'll find the link to it and I'll put that up because I'm sure he's talked about community allocation stuff in there as well.
There are these benefits as well, aren't there? Psychic benefits, if you like, from people actually being involved in the decision making as well as decisions being good decisions.
Yes, yeah.